So I've got a tall order. I'm going to talk about functional abdominal pain disorders in infants and children. So I guess I should start off by asking the question, what is a functional GI disorder? So the Rome Foundation are really responsible for coining this phrase of functional GI disorder. So essentially, it is a disorder of the digestive system in which symptoms cannot be explained by the presence of a structural, tissue, or biochemical abnormality. And you have a range of these disorders. So therefore, if you can't diagnose it using these modalities, then essentially it's a diagnosis based on clinical symptoms. Now that doesn't mean that there are no structural tissue or biochemical abnormalities. It just means in routine clinical practice, we are unable to detect those. But if you actually look at research, as shown in this cover image from gastroenterology, talking about the Rome 4 criteria, you can see that we actually understand a lot more about the pathophysiology of these conditions. And in fact, later on, I'm going to talk about recurrent abdominal pain. And we can see that in the old days, we used to just think about psychological factors, but now we know that there's a genetic predisposition, which probably plays a role, early life events, and I'm going to talk a little bit about this later on. We know that children that get gastrointestinal infections are more likely to get recurrent abdominal pain. There can be a mild inflammatory change. There can be changes in motility. We know a lot about changes in the microbiota within the bowel. And the ultimate result is that you change the sensitivity of the bowel, so you get visceral sensitivity. And this is known as a biopsychosocial model for recurrent abdominal pain. So I'm going to start off by talking about colic. Now, I'm sure that all of you see children who present to you with infantile colic. And this was described more than 60 years ago by Ray Illingsworth in Sheffield. And he described a typical scenario is of a baby aged between 3 days and 3 weeks who develops violent screaming attacks in the evening, usually between 6 p.m. and 10 p.m. He behaves normally during the day, sleeps well at night, apart from demanding the usual night feed. And then he goes on to describe what these babies do. They get flushed in the face, they get a painful expression, they'll often bring their legs up. And that's why it got coined colic, because everybody assumed that this is about abdominal pain and colic. But to this day, we do not know where actually this discomfort, if anything, comes from in these babies. So the Rome 4 criteria, which were published in 2016, define infantile colic, that the infant is less than 5 months of age, he gets recurrent, prolonged periods of infant irritability, fussing or crying, that the parents report, that occur without obvious cause and cannot be prevented or resolved by caregivers. But importantly, these children are otherwise completely well. They're well, healthy-looking children. Now, if we look at the infancy, you see that these functional GI disorders are by far most common in the first few months of life. So whether you're talking about regurgitation, colic, or constipation, if you look across a lifetime, they are by far the commonest within the first few months. So I guess the question is, why? Why are functional GI disorders so common in the first few months of life? Well, if we think about development, we know that children have to go through a considerable change in growth, development. They have to adapt to the environment. And whether you are looking at a newborn baby, the situation is very different in an older child and really changes across. But what we now understand is that there's really a lot of vulnerability that occurs within the first few months because of this rapid change in growth and development. And not only may this increase the risk of these babies presenting with certain conditions, but also what we now know is that there can be early life programming where an issue occurs within the first few months of life that goes on to cause problems like abdominal pain a bit later on in life. So if we look at that first few months of life, we see that the babies are undergoing a huge amount of developmental change. The lining of the intestine is changing, so you're starting to get a more mature villus and crypt-like structure. There are going to be changes within the immune system, so you start to develop Peyer's patches within the small intestine. For example, as you cross over birth, you're going to change from innate to adaptive immunity. And if you think about the intestine as a beach, which is not colonized by any bugs before birth, what happens at birth is you, of course, depending on your mode of delivery, depending on your feeding, depending on the microbes that the babies have been exposed to from the skin, you will start to colonize this beach. But of course, the first bugs that colonize this beach have to fight for space. So it's like a war which is occurring within the bowel itself. And it takes a considerable period of time before they all settle into a more stable environment within the beach. And we know this because if you actually look at the stool of a baby, and the stool color and the stool consistency is really dependent on the microbial populations, you can see that you get a gradual change from meconium to the transitional stool, and this continues to change as you move through the first few months of life. But perhaps one of the most important things is that around birth, children start to develop their sensory interaction with the environment. So for the first few months, they're beginning to see, they're beginning to get a lot of information which is coming from the environment, but this happens before the higher cognitive functions arise. So these babies get a lot of information, but they can't actually work out what is going on in the environment. And I don't know about you, but if I was a baby with this war going on, with all this information changes going on, I would cry the hell out of the place. And that is exactly what happens. Because if you look at normal crying, this is a normal crying curve of a population of normal infants. You'll see that they start to increase crying from 2 weeks, they peak at about 2 months, and they can vary from children that cry very little to children that cry an extreme amount. And in fact, if you looked at a population of infantile colic, you'll see that the graph is virtually the same. They start to increase their crying, they peak at around 2 months, and then they gradually resolve. So that asks the question, well, maybe infantile colic is just the extreme of normal situation. Maybe it's no different to what you would expect within normal. But of course, it depends on other things as well. So for example, there was an interesting study which looked at infant crying across the world. And it showed that, unfortunately, if you were a baby growing up in Canada and the UK, you were much more likely to cry for 3 hours a day or more. Whereas if you were in Japan, only 2% of babies were crying for 3 hours or more. So, of course, there must be other influences as well. Now, there's many, many theories which people have tried to explain why infantile colic occurs, from maternal stress, overfeeding, circadian rhythm. Why? Because why do babies cry in the evening? Why is it so specific that they are well during the day and they cry in the evenings? But none of this has really been proven at all. So people will often interpret and say, well, this baby's got gastroesophageal reflux. This is why they're crying. But in fact, if you study gastroesophageal reflux in these babies with infantile colic, there is no association at all with reflux. So this is increasing reflux as you go to the right, and you see there's no increase in crying time of these babies. So there is no association of gastroesophageal reflux and infantile colic. People have suggested that maybe it's changes within the microbiota, and there are studies which show a reduced diversity within the population that have colic, also suggesting that there may be an increase in fecal calprotectin in these babies, and maybe there's an inflammatory condition that's going on. But in fact, the inflammatory side has never really been proven, although if we look at the microbiota issue, there are studies which suggest that there may be subtle changes that occur within the bowel in children with infantile colic. But like anything, is it the chicken or is it the egg? All right? Are we really looking at the causative factor for infantile colic or not? But on a practical front, so this baby presents to you, how are you going to approach this? How are you going to approach this very common condition that we're saying is prevalent in about 1/4 of all babies? Well, like anything in life, you have to use your clinical your normal clinical approach in these children. You take a history and examination. You make sure that there's no kind of red flags which are flagged up here. This is an algorithm which was published along with the Rome criteria. You want to listen to the cry, because the children that have neurological conditions may have a classical high-pitched painful cry, or children who have more painful conditions. In the UK, I'm not quite sure how big the situation is here, but in certain pockets, we also have to think about maternal ingestion of drugs, because often these children will withdraw around this time, and you need to have it at the back of your mind that this might actually be occurring within these children. And also, if the symptoms are happening after 4 months of life, if they're actually coming later on, not what you would expect within a normal situation. We're seeing so many more children who present with allergy that, in fact, in this algorithm, it really says that if you've gone down and you've followed this child and there's excessive crying, if there's a history of atopy, if there's a history of mucus within the stools or blood within the stools, if there are any issues around growth, then you may have a time-limited challenge of removing cow's milk protein from the diet to see whether it may improve the situation. But most families, as you know, are going to actually resort to drugs. They're going to try and find some sort of medication or herbal remedy to try and sort out these children with infantile colic. Is there any evidence for their use? In fact, no. So if you look at this Cochrane database review, there are no studies which give us sufficient evidence to say that there's any one drug or herbal remedy which is effective in infantile colic. What about PPIs, proton pump inhibitors? I mean, the amount of babies that get given proton pump inhibitors in an effort to try and reduce their crying is huge. If you look, this is in fact an old amount of data, but there's an exponential increase in the prescription of acid suppressants in babies like this. And of course, it's completely incorrect because there's no evidence to show that it has any impact on improving these babies. And in fact, now there's good evidence to actually tell us that there's significant side effects which vary from bacterial overgrowth to poor bone health, possibly even increasing allergy and causing changes within the gut as a side effect. What about probiotics? I've talked to you a little bit about changes within the bowel. Well, there are some studies which suggest that there may be a marginal reduction in crying time. So there's a systematic review here, for example, that I show you, which suggests that the use of this probiotic Lactobacillus reuteri may reduce crying time by about 50% within this. But the problem is that how do you select which infant you're actually going to use this effectively within? They're going to get better on their own accord. So there's a real question to whether we should actually be stepping in with anything at all within this population. So how do we actually manage this condition? And what I'm going to suggest to you that, in fact, management is really about parental education and reassurance. If you're convinced that this baby is healthy and is otherwise well, then I don't think you necessarily need to step in with anything. You need to spend time with the family to explain the normal evolution of this condition, a normal crying infant, and how that may progress over time, and try and bring the family on board with you. So I'm going to move on to functional abdominal pain disorders now. So again, they're very common. About 1 in 5 children during school age will present with episodes of recurrent abdominal pain. We used to think just about the psychosocial influences and talk about stressed children and stressed families and it occurring, but we know as many sensitizing psychosocial events there are also these sensitizing medical events, such as gastrointestinal infection. And these occur within individuals that may have a genetic predisposition, so we're much more likely to see parents that also have recurrent abdominal pain or chronic pain. There may be early life events which then sensitize the way that the bowel deals with pain. We no longer refer to this group as recurrent abdominal pain. We call them functional abdominal pain disorders, and we then subdivide them into abdominal migraine, functional dyspepsia, irritable bowel syndrome, and functional abdominal pain not otherwise specified. Abdominal migraine is similar to what you would expect within headaches or migraine that occurs in the spasmodic sense. Functional dyspepsia is pain tends to be more in the upper gastrointestinal tract, and it may be influenced by feeding. There are the early satiety or feed-related symptoms. And irritable bowel syndrome is classically pain which in some way is associated with change in stools or with defecation as well. So let's kind of think on a practical front. So this is the clinical problem. So this is the scenario. So mom is brought this baby or this child to you. This could be a 12-year-old girl who's suffering recurrent abdominal pain. Of course, we all love as pediatricians to see children with recurrent abdominal pain. It really is the best kind of case that you can deal with because you know that it's really going to spoil your day. So the nurse that's bringing in the patient says, Dr. Thapar, your next patient is one of those patients with recurrent abdominal pain. But you know, Dr. Thapar, she looks completely fine to me. But the mum, she looks a bit scary. And be careful, Dr. Thapar, because the father is 6'3" tall. Then, of course, you're sitting in the room waiting for this child. This is your recurrent abdominal pain clinic. What are you thinking? You're thinking, oh, yippee, yippee, my favorite kind of patient. There goes my afternoon, my day, my week, my life is going to disappear. Then you think, okay, what I'll do is I'll do some bloods, I'll do an ultrasound, and I'll get rid of them, because that's the easy way. But of course, you're all experienced pediatricians, you wouldn't do that. You would, of course, say, I think I'll get my junior doctor to see this one, because I can't be bothered to do that. But in fact, we shouldn't be approaching these children like this. You need to understand why they've actually come to you, because if you don't understand why they've come to you, you won't actually be able to deal with this at all. You need to differentiate organic disease from functional disease. You need to think about triggers, because there's always generally triggers for these sorts of issues. And then finally, you need to subclassify the type of functional abdominal pain disorder and start to think about the most beneficial therapy. So of course, in terms of red flags, it's the usual things that you need to think about. You need to think about a family history. What is the growth like? Is there a weight loss? Is there unexplained fever? Pain that wakes a child in the middle of the night. Traditionally, we always just say that if pain wakes the child at night, it must be organic. But in fact, there's really good data which has now shown that in fact it's not a good discerning thing. And if you take a history from a child with recurrent abdominal pain, they'll often sleep poorly. They'll often wake up. They sleep more during the day. They're more awake at night. It's not a very good discerning factor. Then, of course, you go on to an examination. You need to ask about early life. Why do we ask about early life? Because we know that this vulnerable period may increase the chance to get recurrent abdominal pain later on. And in fact, there's lots of studies now to suggest even things like gastric suction at birth, early surgery, cow's milk allergy within the infant period, gastrointestinal infections, use of antibiotics may predispose you to develop recurrent abdominal pain even 10 years after the event occurred. And we know this very well for infections. So this is a multi-center study which was run by Miguel Saps in the United States when he was in Chicago, which showed that if you follow up children who have Campylobacter, Shigella, Salmonella, proven infections, and you follow them up, they're much more likely in the following months to go on to develop episodes of recurrent abdominal pain. And these are children that were otherwise completely well. And in the mid-1990s, there was an outbreak of Salmonella in Bologna in Italy, and they followed up children and adults who had proven Salmonella infection. And it was the children 10 years after this outbreak that started to present more with recurrent abdominal pain. So it seems that there's some sort of programming that occurs of the nerves, and then as you approach puberty, perhaps, you start to then develop this symptom of recurrent abdominal pain. You need to understand the nature and severity, and what I tend to do is to send them away for a couple of weeks. I give them a diary, because I want to see, are there any particular triggers? Does it come after meals? Is there anything that may give you some sort of sense of what is going on? For the younger children, you can use pain rating scales if you want to actually get them. But the only warning I give you is that most of them are actually going to keep on recording on the higher level. And then, of course, you need to run through the rest of the history. And I only wanted to draw really your attention that you've got to keep a third dimension in the back of your mind, and that is really about things like psychosocial issues and issues around child abuse, because we underestimate this within the pathophysiology of this condition. You go on to take an examination. Of course, this is nice and straightforward. You'd make an instant diagnosis of celiac disease within this child, but you need to do a careful examination, again, thinking about the presence of something which may alert you to other issues going on. Now, constipation, there's certain practices, I know in the United States and the UK, which they pretty much in every child would use laxatives as a trial to see if there's an improvement in abdominal pain. Now, it does seem that there may be constipation you need to look after, but do not get the message that all of these children have constipation. So a critical question, should you do any tests in these children? You've examined this child, you've taken a history, the child seems fine. Should you do any tests routinely? Now, previously, we had this statement of no evidence of anything, and the general rule was don't start doing tests on these children. But thankfully, the new Rome 4 criteria says use your clinical judgment. Use your sense whether you actually need to do a test or not. So interestingly, if you look at certain conditions, for example, celiac disease, so there's this large Italian multi-center study which showed that if you look in a population of children with irritable bowel syndrome, for example, they were 4 times more likely to have celiac disease than a general population. So there are certain conditions which perhaps we should be looking for within this population of children with recurrent abdominal pain. Now, my personal practice, and this is really kind of shared with Mark Benninger in the Netherlands, is really if you've gone through this algorithm, that as a minimum, you may consider to do full blood count, look at inflammatory markers, consider to do celiac disease screening. In older children, a calprotectin may actually be very helpful to make sure that there's no issues around inflammatory bowel disease. You may look for infection within the stool, but you don't really need to do anything else because there's no evidence for it. There is no evidence to look for Helicobacter pylori. It has no association with recurrent abdominal pain. And there's numerous studies to actually show that. In the absence of ulcer disease, there is no association of Helicobacter with recurrent abdominal pain. So just to finish off, how do we manage these conditions? Well, you need to spend time. If you try and do this in a 10-minute consultation, they'll either never come to see you again, or you will have to spend 10-minute consultations. So you might as well just do it in the first instance. So you want to encourage a positive attitude, but realistic expectations about what is going to happen to them. So you want to talk about how common these disorders are. I always discuss a biopsychosocial model, why they may have ended up in this situation. That it's a benign clinical course. So children with irritable bowel syndrome don't die from irritable bowel syndrome, but I can tell you that there may be children that die from what the physician does or in terms of trying to treat it. So you have to be careful about that. You can often get intermittent symptoms. Quality of life can be very low for these children that get recurrent abdominal pain. And although you may not be able to cure it, most patients are actually going to improve with management. So what management can you apply? Diets. There's a lot of work now looking at special diets like low fermentable diets, like a low FODMAP diet. There is some emerging evidence to say that it might impact. But if you've ever put a child on a low FODMAP diet, these are very, very restrictive diets. And there is some information from a study done in the UK at the moment about trace element and micronutrient deficiencies within these. So you have to be very careful. At this moment in time, there is no clear diet to put children with recurrent abdominal pain on. Probiotics, again, really just very little data to suggest that you may impact a little bit on recurrent abdominal pain. But again, it's not really a treatment that we currently suggest to put every child on who comes to you with recurrent abdominal pain. Medication. In fact, as summed up in this Cochrane review, at this moment in time, there's no one drug that has actually been shown to be beneficial. But I'll tell you something. Here's a good example. This is a multi-center study which is done in the United States in adolescents looking at the use of amitriptyline for reducing abdominal pain. And it had a fantastic effect. They started to report much lower scores in pain intensity. This is a randomized controlled, placebo-controlled trial. And this is the placebo. The placebo had the same effect as the actual use of the drug. And this is the biggest challenge we have in functional gastrointestinal disorders, is that there is a huge placebo effect of up to 50%. And we know that really well. And in fact, in the United States, in the adults, there was a great study where following a randomized controlled, placebo-controlled trial, they then did an open-label placebo trial. So the adults knew they were on placebo. And all of the adults came back and said, you know, I don't know what it is, but this is really making me feel good. Can I please continue to take this empty capsule, which hasn't got anything in it at all? So that placebo effect is quite dramatic. But in fact, the component, when it's been looked at, of what is the placebo effect, it's mostly you. It's mostly you as clinicians that have to start on the right foot, because if you are effective, you will actually manage these children effectively. And if those of you don't see any children with recurrent abdominal pain, you're either hepatologists or you actually don't spend enough time dealing with these children. Now, this is interesting because there may be parent interactions as well. Lynn Walker in the United States did a great study where what she did is she tried to induce pain by these children drinking a large volume of water and gave the parents 3 instructions. Either distract your child, they didn't give any instructions to the parents, they do what they normally do, or pay attention. You poor child, your pain is so bad, what can I do to help you? Look at the difference in pain reporting in those 3 scenarios in the same children in 3 different instructions. So there are parental influences. And in fact, the funny thing is in that when the parents were asked what they thought about this study, they thought it was terrible that they had been asked to try and distract their children. So if there's no diet, no drugs, what are we going to do with these children to actually make them better? So what's the treatment? Well, in fact, the best amount of evidence comes from the use of psychological interventions. So, for example, cognitive behavioral therapy, where you're changing the behavior or the responses to pain in the child and the family. Rona Levy in the United States showed really good. So if you put cognitive behavioral therapy in the red, you can see there's really good improvements compared to standard education within these children. And she followed them up for 12 months to show that it was still effective. But perhaps the best piece of work comes from the Netherlands group of Irene Vlieger and Mark Benninger, which showed that the effect of hypnotherapy, where the children are getting control of the pain, was so dramatic, it was far better than any placebo effect that they could actually induce or any standard medical therapy applied. And they then went on to show that it was effective up to 5 years. So in terms of prognosis, what happens to these children with recurrent abdominal pain? Well, it's a 50-50. 50% generally get better, 50% continue to have symptoms. But we actually don't know what happens to this group that did so well with the hypnotherapy. So in terms of, there's no predictive factors. You can't pick out the children that were going to do bad at the end, but I will tell you some factors which may help you. And these are these ones. If the families refuse to accept that there's a psychological benefit in therapy for their children, if they refuse to engage with it, if they actually see more than 3 consultants, so they see 1 consultant, they're not happy, they go and see a 2nd consultant, they go and see a 3rd consultant. All right, I can talk through it.
Go to the conclusion slide directly.
In fact, this was my last slide. So, and then nausea. The other factor is nausea. So children who have recurrent abdominal pain with nausea, they also actually suffer from quite prolonged symptoms. And if you don't manage these children effectively with psychology, they end up getting depression and other psychiatric disorders. So therefore, to conclude, you need to address the concerns and questions of these families, use red flags to guide investigations, choose a diagnostic plan, but have clear objectives that you share with the family. Explain a negative test is good news. Make a confident diagnosis. Don't say, oh, I don't know, you've got recurrent abdominal pain. Say, I know, your tests are negative, your symptoms tell me you have irritable bowel syndrome. this is what irritable bowel syndrome really means for you. Okay? And in terms of trying to treat them, it's really this psychological approach involving the parents as well, which is most likely to be beneficial to these children. And with that, I'm going to draw to a close. Thank you very much.
Thank you, Dr. Thapar, for that wonderful talk.